Hello everyone, I'm Dr. Shweta, and today from the Ocular Surface Gurukul, we are here to present our new series, Chronicles with Experts, where we hear directly from the experts, the people who have actually shaped the way we manage and understand ocular surface diseases. It's not about textbooks or protocols, but it's about real life lessons learned under pressure, challenging situations which have been faced with wisdom that only experience can offer. And who better to kick off this series than our very own Dr. Chetan Rao, Senior Vitreo-retinal Consultant at Sankara Nethralaya, Chennai, India, our go-to backup person in every challenging situation, an integral part of our ocular surface team at Sankara Nethralaya, Chennai. Leading this insightful conversation are Dr. Varsha and Dr. Mukundan, again an integral part of our Ocular Surface Gurukul, who will be picking Dr. Chetan's brain for everything from tricky decisions to unexpected learnings. Over to you guys.
So thank you, Dr. Shweta, for your kind introduction. So in this episode, we'll be unpacking the vitreoretinal side of the K-Pro from pre-op challenges to surgical challenges and post-op care. So let's get started. So Dr. Chetan, let's start from the beginning of the journey. So before committing to a keratoprosthesis, assessing retinal health is very crucial. So how do you approach these patients preoperatively?
So good evening, Dr. Mukundan, Dr. Varsha, and Dr. Shweta. Thanks for letting me join your podcast, and I'm glad to share my experience with you all. So coming to the question, approach is really basic. You have to assess the PL status and check the status of the retina on the ultrasound, because you don't have a view of the posterior fold. So if the patient has PL and has no retinal detachment, then we can proceed with the K-Pro and vitrectomy and prognosticate vision on the basis of what we see intraoperatively about the disc status and the macular status. If the patient has perception of light and has retinal detachment on ultrasound, then the visual prognosis can be very guarded, because the RD in the ocular surface disease is most likely to be tractional in nature, and rarely it can be due to a complication secondary to a perforated eye in an ocular surface disorder with a choroidal detachment and subsequent RD, and sometimes a closed funnel RD and kissing configuration type of choroidal detachment can be really bad for the prognosis. So, and secondly, when you know that there is a ocular prosthesis is going to be there, so usually in this case, we end up putting a silicone oil inside the eye when we know that there is a limited potential of vision, but there's still a vision. So we keep oil in situ and maintain it, because most of these ocular surface cases have hypotony, because there's a lot of ciliary body atrophy. And the cases which I would really defer surgery is which appear small in the ultrasound and having a closed funnel detachment. I'd be very skeptical of operating those cases, even if the PL is present, and sometimes it could be doubtful.
So, sir, that's a very systematic approach, sir. But sometimes, even after a thorough clinical examination and an ultrasound evaluation, there are certain gray areas where we still want to have a better look inside. So, in your experience, where does diagnostic endoscopic visualization fit in, and how do you decide which are the patients which are suitable for it?
So, if suppose in the ultrasound you find the retina is attached and there is a PL inconsistency, and you have say probably a doubtful optic atrophy or a glaucomatic optic atrophy, considering the IOP appears high, and now you want to be really sure before you want to attempt a vitrectomy or add a glaucoma device. So those cases, I would definitely want to go with a diagnostic endoscopic evaluation, because the endoscope gives a good idea of the optic nerve health status and also tells us about the ciliary body status. And if both the optic nerve and the ciliary body appear salvageable, then of course we go ahead with the ocular surface procedure along with vitrectomy and the AGVs or other procedures that you do.
Very valid points, Dr. Chetan. So now we'll move on from pre-op evaluation to actual intraop challenges. So the two most common intraoperative hurdles as a VR surgeon you face are handling the retroprosthetic membranes as well as endophthalmitis. So let's take them one by one. So starting with membranectomy, could you share your key pearls for tackling them effectively?
So the Boston K-Pros have these recurrence of retroprosthetic membrane growth, which happens after a certain period of time. And these retroprosthetic membranes are right behind the prosthesis covering the optical cylinder. So when we enter the eye, we would usually enter it. We usually make the sclerotomy as usual around 3 millimeters of the limbus, but we enter the eye horizontal to the iris, and so this way we go parallel to the retroprosthetic membrane, and if we go a little horizontally along the horizontal meridian, we get the best angle of the fulcrum to sweep using the trocar itself uh, and engage the retroprosthetic membrane and cut it. Many times you might see this prosthetic membranes are vascular, and the same approach, you go parallel to the iris, to the sclerotomy with the cautery, and you cauterize uh, those vessels, and then you cut with a cutter. Sometimes they are really stiff, and then you might have to use a scissor to cut it. And even then, the approach is always horizontal, because being parallel to the prosthetic membrane gives us the best what do you call field to cut the membrane completely on the opposite side of the sclerotomy. And then you chop it off with the cutter, and keep using cautery to cauterize the edges. And one good useful tip is, when you cauterize the tissue, even that shrinks and that retracts to the periphery. So the cautery helps in even retracting the tissue, and you actually have to do less maneuvers to cut the tissue altogether.
Very insightful, sir. So the second most common complication is endophthalmitis in such patients. And when it comes to endophthalmitis, especially in these unique cases, does your management strategy differ in these cases from the routine VR cases? And if so, sir, how does it differ?
So in the MOKP cases, usually you will have a sterile variety of vitreous reaction, and hence most of the times we get by giving oral steroids. And whereas in the Boston K-Pro, there's a definite risk of endophthalmitis because the ocular surface could be compromised. And when you first see a vitritis or a vitreous reaction, it's impossible to give an intravitreal injection. So most often we start off with admitting the patient and starting broad spectrum IV antibiotics along with steroids, because most of the cases usually are bacterial endophthalmitis. But if after 2 or 3 days of observation, this vitreous reaction doesn't clear, then we may have to do a vitrectomy, for which we may have to go to the theater, reflect the ocular processes, use a temporary keratoprosthesis, and do the vitrectomy, and give the intravitreal injections. And if it is rarely a fungal infection, of course, the approach is you don't wait for too long. If the IV antibiotics are not working, you immediately take up, because there's no other way to take a sample as well. So the only way you can take a sample is by doing vitrectomy in those cases.
Oh, thank you, sir. Sir, we also know that VR surgeries like membranectomy and endophthalmitis is much more complex in handling type 2 K-pros as well as in MOKP. So, can you share us the unique challenges in these situations and adjustments you make while handling these cases in type 2 K-pro or MOKP cases?
So as I mentioned, MOKP cases, it's really tough, because the problem is not that the K-Pro, if it is stable and everything is all right, and now we are suspecting that this may no longer be a sterile endophthalmitis and you have to go inside the eye. The K-Pro plate is the MOKP bony lamina is rectangular in shape, and hence you have to adjust your sclerotomies according to that lamina. So you have to go a little further away from the lamina, and roughly we take around 8 millimeters from the center, which helps us in putting the sclerotomy around 3 millimeters from the supposed limbus, because there's no limbus there. And then you have to go a little horizontal away from the rectangular lamina to enter the eye. So it can be a little tricky, but the MOKP cylinder gives a good view of the retina. And since we're not going to do too much of a vitrectomy in cases of endophthalmitis, we just get by taking a sample and quickly doing the vitrectomy. Whereas in type 2 K-pros or type 1 K-pros, the situation is the same. It's actually more easy. The only work is that you have to reflect the K-pro or replace the K-pro with a temporary keratoprosthesis and do the surgery, and then maybe replace the K-pro at a later date. So in the type 2, you'll have to reflect the skin and then proceed with the procedure. Whereas in a type 1, you can go directly through the conjunctiva, and you can, so that's the only challenge in type 1. In the type 2, you'll have to actually reflect the skin to be able to approach the ocular surface.
Building on that, sir, sometimes to address the pathology completely, you may need to remove the K-Pro and put a temporary one. So in what kind of VR scenarios that you push you towards doing that kind of like putting a temporary K-Pro?
So temporary K-Pro is basically definitely if there is an infection, I would rather have a temporary K-Pro and do a thorough job of cleaning up the vitreous, and if there is a associated little detachment, taking care of that. And rarely in cases where there is a focal little detachment because of a traction in the periphery, but the posterior pole is attached, then you would like to reach the periphery and need to have a complete vitrectomy. But in most cases of retinal detachment that happen later on after the K-Pro is placed, many of them are total RDs due to tractional detachment and hypotony. Sometimes there's reg RDs. In those cases, what we generally do is with the K-Pro itself, in situ, we have a reasonable view, around 50 to 60 diopters view of the fundus is there, where we can do most of the procedures. We can even do a retinectomy, LPFC, oil, and all the maneuvers can be easily done with a little bit of adjustment of the biome. The only trick is that the type 1 K-Pro, though it gives you a 60 diopter view, you have to always center the biome on the K-Pro. Otherwise, a little movement of the eyeball and the view completely vanishes. Whereas in type 2, it's even worse because the cylinder is very long and the view becomes narrower. And that's also a challenge. So whenever I have to do extra work in the periphery, like a dissection in the periphery, membrane dissection in the periphery, maybe even a diode an endoscopic endophotocoagulation, I might have to ask to do a temporary K-Pro, and then of course replace it with a Boston K-Pro.
So thank you, sir. You have partly answered the next question also. So does the same principle of temporary K-Pro holds well for type 1 K-Pro also, as the type 1 K-Pro comparatively gives a wider view than in type 2 K-Pro?
So yeah, so which is what I made a point before, that the type 1 K-Pro allows you almost 60 diopters of field of view, whereas the type 2, because of the long cylinder, doesn't give you enough. So it will be useful to remove the K-Pro for peripheral dissection and use a temporary K-Pro. If you are looking to a temporary K-Pro, we would prefer the PMMA K-Pro, which is more stable, is less leaky. because you can use it multiple times. Whereas the silicon plate K-pros are generally, if you have used it 2-3 times, then the suture tracks leak. So though they give you a wider view, the silicon plate gives you a wider view of the anterior pars plana and pars ciliaris. The Landers K-Pro, PMMA K-Pro gives a little less anterior view, but both are sufficient for the posterior segment view.
You have answered our next question also. The next question was we would like to ask you the which of the two temporary K-pros you will prefer, either a silicon one or PMMA one, but you have already answered the questions. Thank you, sir. Now we'll move on to our next question. Let's talk about the instrumentation. So what's your go-to instrumentation for these surgeries?
So the modern small gauge vitrectomy are quite fragile instrumentations, fragile instruments, the cutter, tubing, the endolaser. But the 23 gauge offers the best compromise with the long length and the stiffer instruments. So they don't bend easily, and you are able to uh, approach the sclerotomies easily. You don't have a problem with them. 25 gauge is usually a little bit of problem, and we reserve the 25 gauge for simple vitrectomies where ultimately we are going to use the pars plana AGV tube insertion through the sclerotomy. So I would prefer a 23 gauge for most of the vitrectomies, especially when I'm anticipating a lot of vitrectomy work with, say, for example, additional membrane peeling, retinal detachment surgery, those kind of cases. But simple vitrectomy, 25 gauge is sufficient.
And sir, in scenarios where we need to put oil in the such cases, any specific concentrations of the oil would you like to use? And if so, then what is the reason for that, sir?
So the silicone oil that we use, mostly we prefer to use higher viscosity silicone oil. The higher viscosity means higher interfacial tension, which means it emulsifies less. So many of our patients already have glaucoma, and keeping an oil for a very long time, we prefer a higher viscosity one, which doesn't emulsify easily. And also, the view remains clear throughout. Otherwise, emulsified oil, when it starts emulsifying, it can obstruct the view, and already they have a very small field of view. So prefer a higher viscosity oil like silicone oil 5000 centistrokes.
Thank you, sir. So once the surgery is done, the story doesn't end there. How do you evaluate the posterior segment of these patients post-operatively, especially when the fundus view is less than ideal in these patients?
So if the view is clear, for example, the cylinder is absolutely straight and there is no media opacity. In most cases, you're able to see the disc and macula within that ophthalmoscope. And with little tilt of the eye, especially in type 1 K-Pro, you're able to see a little beyond the arcades as well, and nasal to the disc. But sometimes the K-Pro being a PMMA material, the surface can become dry, and the surface of the cylinder is dry, so you're not able to clearly see the media. You have to wet it a little bit and then again visualize it. So the one easiest way and the quickest way to evaluate the fundus is doing an optos wide field imaging, and that allows a pretty good view up to the mid periphery. So if the view, if the cylinder, the view is clear, there's no media opacity, then you get a very good view of using an optos. And if you suspect any macular pathology, then you can do a SWEPSOS OCT or any SD OCT having more than 1 lakh scans per second. That allows us to look at the macular structures very nicely. We're able to make we were able to make some what do you call, get some information from the OCT regarding the macula and treat accordingly. So, Optos, a combination of Optos and OCT allows us to monitor these patients and see if there is any pathology which is affecting the vision, or if there is a recent vision loss, we can actually use these modalities to guide our treatment.
Thank you, sir. Thank you so much for those pearls. And finally, sir, what will be your parting advice for the budding PR surgeons who are just beginning to work with these complex K-Pro cases?
So, the surgery is complex, no doubt. There is a lot of challenge in operating these cases. You have what do you call first you start with the difficulty of sclerotomy placements, then the surgical view is very less, it's limited. You can't maneuver so much that you can't do a scleral depression to look at the to approach the periphery of the fundus. But if you're able to overcome these challenges, doing this surgery is very gratifying, because the patient, very next day, the patient is able to move around. A person who comes blind into your outpatient is now able to move around very confidently. And that is very gratifying for any surgery, because I mean, it is the best thing to see that the patient is satisfied and there's a smile on his face or her face, and their life has got totally changed with this kind of surgery. So I think people should take up these challenges, because doing cataract surgeries and routine surgeries are, of course, satisfying, but nothing is more satisfying than seeing a blind patient walk the very next day.
So thank you so much, sir, for sharing your valuable insights. We learned a lot. So we hope our viewers also found this discussion very useful. So for any queries, feel free to reach to us at osg@snmail.org. Until next time, keep learning and keep digging deep into the surface. Thank you. Thank you so much, sir.
So thank you to all the Ocular Surface clinicians who have invited me, and we had a great discussion. Thanks to Shweta, Varsha, and Mukundan. And if you have any queries, you can always leave your comments in the YouTube channel, and if possible, we can answer there, or you can always email to us. So goodbye, and thanks to all of you. It was a pleasure.
Thank you so
Thank you.
much. Thank you.
Thank you.
Thank you, sir.